name yourself if you are not in the class with your name. You can see an iPhone in the participants list. Rename yourself. Okay, so I'm starting this class now. And as I have said before, I expect that you should have read the materials that have been shared, and then we will do a general discussion around the information that you already have using this PowerPoint lecture as the basis for the discussion. So I'll just quickly go through this presentation, and then we'll take questions and discussions thereafter. So you know that the title of the course is The Pharmacist in the National Health Plan. And the whole purpose of this course is to prepare you for your roles in interacting with patients going forward, at especially at the primary care level, where you're supposed to provide basic care, treatment for non-communicable diseases, while providing appropriate pharmaceutical services in the delivery of your work or your activities. So the basic health paradigm for the country is based on the primary health care system, where it is believed, based on the Alma Ata Declaration, that primary care is where the majority of the healthcare needs of a country is met. At that primary healthcare level, over 75% of the healthcare needs of the people is expected to be dealt with, such that it is only the 20 to 30% that need more sophisticated care, that need more, that have more complicated issues, will move up in the line to secondary or to tertiary care facilities. You know, so the origin of the primary healthcare system, as I said, is the Alma Ata Declaration that was made with several heads of governments agreeing to work within the healthcare space in their countries to promote primary healthcare. Now, pre-PHC, Nigeria underwent different forms under the national development plans. And it was in the third care was not really a focal point of those plans, and there was therefore very limited success in terms of healthcare development. So using that National Development Plan, Basic Health Service Scheme was introduced, and this was an ambitious plan, heavy on infrastructure and auxiliary health manpower development. You know, so the plan was that there will be a basic healthcare service that was determined to be the basic minimum that will be available for every Nigerian. However, even though it was supposed to be basic health service, the planning was too ambitious, with heavy dependence on infrastructure that was not available, and health manpower that was also not available. The third National Development Plan failed to share responsibilities between the three levels of government for resource generation, manpower development, the various services to be delivered, and especially on the health professional manpower for the services. And this all happened in the absence of a clear policy framework. In terms of development, once a plan is made that is not backed by policy, it means that implementation will at best be fragmented. At worst, there will be no implementation at all. Because it is policy that guides action. When there's a policy in place around a particular activity, everybody involved in that activity has clear directions on what they need to do to ensure that the policy is met. But when there's a plan without a policy, then everybody comes in, does what they think they should do it the way they think they should do it. Or some people may even decide that, oh, we're not interested, there's really no need. And so there's a lot of fragmentation. For instance, that's where we are around public health pharmacy, as well as pharmacists' involvement in immunization. While there's a policy on immunization, there's no clear mention of the pharmacist's role in that policy. Also, there's the policy around public health, but again, there's no clear mention of the path, the path for pharmacists in that policy. And so you find, you go to pharmacy A, they say they are practicing public health, they are doing it in this certain way. You go to pharmacy B, they are doing their own in another way. You go to another place, and so there's no order, there's no plan around what is going on. So I mentioned this Alma Ata Declaration. The 30th World Health Assembly in 1977 agreed on the vision for all by the year 2000. We're 21 years away from the year 2000. We still don't have health for all anywhere in the world. So, however, the teaching around health for all is still important because it was a major social target for governments, international organizations, and communities. The whole world was united around trying to ensure basic health care services for their people using this declaration as the fulcrum. The Alma Ata Conference in 1978, a year after that assembly, endorsed primary health care as the key strategy for implementation by all countries so that they can improve the health status of their people and result in achieving health for all by the year 2000. Following that declaration, serious attempts were made at health systems reforms in the 1980s. Declaration formed the basis for a World Health Policy. It served as a basis for formulation of health policies in many countries, Nigeria included. And the National Health Policy was based on the principles of primary health care, and primary health care implementation were the results. This National Health Policy, the first National Health Policy, was released in 1988. Thereafter, we had a fourth National Development Plan. And in that plan, the healthcare services was identified to be too dependent on curative services. And so within that National Development Plan, there was a provision for comprehensive healthcare system offering promotional, protective, restorative, and rehabilitative services to an increasing proportion of the population. So there was supposed to be a national comprehensive healthcare scheme formulated and developed at 3 levels: the primary, the secondary, as well as the tertiary. You will see the definition for primary health care in the next page. But that Alma Ata conference strongly reaffirmed that health, which is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, is a fundamental human right. And this definition of health is accredited to the World Health Organization in 1947. So a person that has no infirmity, no physical infirmity, but is not quite there mentally, cannot be said to be healthy. A person that is physically and mentally fit, but does not have money to pay for his children's school fees, or money to feed his children, or accommodation for him and his family, cannot be said to be healthy. So health, looking at health, it must be as a total package. The conference also affirmed that the attainment of the highest possible level of health is the most important worldwide social goal, whose realization requires the action of many other social and economic sectors in addition to the health sector. You'll agree with me that if we're saying that health is a complete state of well-being, then it cannot just be looking at the health ministry, cannot just be looking at the health sector. You'll be looking at, in addition, the food sector, for instance, food for people to eat. You'll be looking at the environment. What happens about pollution, noise, sound, smell, So you're looking at a totality of sectors that impinge on the health of the people. And there's supposed to be that collaboration between these sectors in order to ensure that the health of the people is maintained. So this slide shows us the definition of primary health care. And you can see that it is not a small definition at all. A definition that takes, is it 7 to 8 lines? It must be something that is really important. And you can see that I put some words or phrases in colors to highlight the importance of those aspects of the definition in ensuring primary health care. So primary health care is essential health care. So the first word we're looking at there is essential. So it's a human right. It is not a gift. It is not something that people have to beg for. It's essential healthcare based on practical, scientifically sound, and socially acceptable methods and technology. I'll stop there. And so when we're looking at primary healthcare, you expect that it should be something that is practical. It is something that is feasible within the limits of the environment where that primary healthcare service is being provided. And so you would understand better why the primary healthcare clinics, or the primary healthcare centers, as we call them, provide basic services. They're not supposed to be dealing in complex things that require complex infrastructure or complex equipment or very sophisticated manpower, consultants or professors and things like that. So the basic care provided at the primary healthcare level is socially acceptable within the environment of that primary healthcare service. So what this is also saying is that the service that may be provided in, for instance, in the Southwest will likely be different from that provided in the Northwest. Basically because the environments are different. What would be acceptable within one area, within these two areas, will be different. So the service that will be provided will be tailored to meet the needs of the people in that environment. So I'll continue. Socially acceptable methods and technology made universally accessible to individuals and families in the community through their full participation and at a cost that the community and the country can afford to maintain at every stage of their development in the spirit of self-reliance and self-determination. Again, primary healthcare is looking at community mobilization, community involvement, community participation. So again, it speaks to the fact that primary healthcare services provided in a certain environment will most likely be different from that provided in another, because what the community will accept in this place is different from what they would accept at another place. So this is the definition for primary healthcare, and it hasn't changed over the years. So the reasons behind this definition, the declaration noted that there was gross inequality in the health status of the people, particularly between developed and developing countries, as well as within countries, which is politically, socially, and economically acceptable. I said this Alma Ata Declaration was made in 1978, and I would dare say that the inequality in the health status of the people still persists till now, and this unacceptable way of activity, let me put it that way, is still very much on ground. We will see, or we should have seen in our notes, some of the reasons why the PHC program failed. Ajayi to missing. So hence, Health for All Y2K was designed to remove all obstacles to health. So the technical definition of PHC clearly indicates the goals and the ways to which it was intended to be directed. First, it was supposed to be people-oriented. Azubike Innocent, mute yourself. It was supposed to be people-oriented. So it's supposed to meet the needs of the people within that area where the service is available. However, it became a popular slogan and a lucrative program at all levels of government without the achievement of much impact. Obstacles to health. Azubike Innocent.
Sit down, not the word.
Yes, ma'am.
Can you mute yourself, please? Obstacles to health include ignorance, and unfortunately, that saying that what you don't know can't hurt you does not work with the law, neither does it work with health. The fact that you don't know that, let me see now, eating too much fatty foods is not good for you does not stop the fatty foods from causing the damage that it will cause in your body. So the more people have understanding of basic things that will help them to protect their own health, the better for the generality of the people. Malnutrition is an obstacle to health. I've mentioned that health as a sector cannot stand on its own when we're trying to achieve complete physical, social, and mental well-being of a people. When people cannot eat, they cannot afford to buy food or to get good quality food, or they don't even know about good quality food, and they are malnourished, their health will be significantly impacted. Contaminated drinking water is another issue that serves as an obstacle to health. While those of us down here, let me say in Lagos or in the city center, as the case may be, we think that this sporadic water supply from Lagos Water, you think that is how everybody has some minimal level of water. It doesn't happen that way. There are many communities that their only source of water is the village stream. It is that village stream that they take water to cook. It is from that village stream that they have their bath. It is from that stream that they do their defecation and urination. It is from that stream that they wash their clothes. The same water. And so when people do not have access to clean drinking water, it of course has an impact on their health. Unhygienic housing. This is another obstacle to health because people must sleep somewhere, I guess. And people can afford different kinds of housing up to different levels. So when the house that somebody is staying is has paper thin walls that brings the smell of everything your neighbor is doing in their room to you, it means that it's also carrying whatever germs, whatever issues from that neighbor to you. When people have their families cramped into one bedroom apartment or one room apartment because that's all they can afford. And so you have the parents sleeping on the bed and the children sleeping somewhere on the floor or against the wall. All this will be detrimental to good health. Olikoye, that was our health minister, said about the Health for All 2000 program in developing PHC system, and it critically identified some obstacles which were preventable and passionately believed that if they were tackled, would help to deliver health for all. Sorry, these obstacles to health were highlighted by Ulikoye, and that if they were tackled, they would help in ensuring health for all. So in the national outlook, the state of our health, we have high levels of diarrhea in children and acute respiratory infection, which are the two killer conditions in children, the two leading killer conditions right now. We still have high under 5 death rate from malaria, and malnutrition contributes to making these children vulnerable to various infections and diseases. School children are beset with fevers, leg ulcers, accidents, cough, anemia, teenage pregnancy, STIs, and drug and alcohol abuse. This is at a national level. For adults, we have road traffic accidents, chronic diseases such as hypertension, diabetes, liver cirrhosis, and cancers. And this is mostly caused by habits, including smoking, excessive drinking of alcohol, and overeating. Of course, road traffic accidents is caused by accident. So you find out that Nigeria, which at one point was beset with communicable diseases, our major problem when I was growing up was infectious diseases. We had high rates of malaria. We had upper respiratory tract infections, lower respiratory tract infections, basically usually linked to our way of life in not protecting ourselves adequately from microbial infection. But Nigeria of today has very high burdens of non-communicable diseases as well as our high burdens of communicable disease. That means that we are beset from both sides, the ones that used to be our problem and the ones that we have imported because of the changes in our lifestyle, the changes in our eating habits, the copying of everything that is done in the United Kingdom and the United States, the way they eat, the way they walk, the way they live their lives. So we have imported all of those lifestyles, and we have, of course, along with that, imported their diseases. We used to say in those days that hypertension, diabetes, it is for the rich people in the advanced countries. That is not our problem. But right now, that is also our problem. Communities also create environments where diseases flourish. When you live in a community that does not have proper drainage, when you live in a community that everybody has to have water storage containers, most of them not properly covered. So we have a ready source of breeding places for mosquitoes, vectors for other diseases. So all this help in promoting diseases around us. Also, community knowledge affects the people in that community. For instance, there are some communities that believe that family planning is from the devil, that it is God that gives. And as long as it gives you children, you continue to accept it. It's a community belief. And so individuals within that community trying to do something different will be viewed as strange. That is when they are being nice. Or they will be viewed more seriously as being demon possessed or something. You know, so when a community's beliefs are anti-health, it negatively impacts on the members of the community. But when a community's beliefs are pro-health, it also positively affects that community. Rural areas have little or no access to health facilities. As I said, the inequalities are not just between the rich and the poor, it's also between the urban and the rural areas. And we still have those that we call hard to reach areas. Areas that after you have parked your car and climbed bicycle and gotten to a point, you still need to enter a boat to be able to get to the community. You can imagine the kind of health service that will be available at the end of that journey. So poverty is rife, inadequate scientific knowledge, babies are delivered in unhealthy environments or discharged to contaminated environments. All these are in our National Health Book. Some solutions, health interventions need to be carried out. We need to find out what is not working and plan programs that will ensure that things begin to work. Intersectoral collaboration is essential for PHC to be effective. Oral health for all is a holistic concept calling for efforts across various sectors. This intersectoral collaboration should be very well pursued. Medical care cannot bring health to a hungry people living in slums. Health of such people requires a whole new way of life and fresh opportunities to provide themselves with a higher standard of living. I remember when the APIN program just started around managing patients with living with HIV and AIDS. And they brought in the drugs, they brought in the documentation, they even brought in some healthcare professionals, you know, but they didn't bring food. And some of these drugs need food to work. They didn't bring accommodation. Many of these people don't even have anywhere to stay. They don't have an income. So in trying to ensure or to make health available, there will always be many other considerations. A typical scenario for us as pharmacists, you're in your community pharmacy, trying to make ends meet, trying to ensure that you meet the needs of your people. And the patient comes in with a prescription. Agbarakwe, mute yourself. A patient comes in with a prescription with 5 items. And you give him, and this happens in the hospitals too. You have identified, okay, this costs this one costs this one costs this. And the patient collects his prescription, looks at it, and tells you, give me just the paracetamol and the vitamin C. The drugs that he needs for his condition, he can't afford them. So he satisfies himself by buying 1 or 2 items that he can afford. When he goes for his next appointment and the doctor asks him, did you use your drugs? Guess what the answer would be? Of course, he will say yes. At least they used something. So medical care in isolation cannot solve the health problems of the people. So we have the principles around which primary health care is supposed to work. And the first one is on equity. We have already talked about the inequalities and the inequity in health. So PHC was supposed to provide a basic platform for everybody. It was supposed to be affordable to the least earning worker in the country, such that everybody can have access to the basic health care that they need. That was one of the principles of primary health care. Appropriate technology is another principle. Since primary health care is supposed to be basic care, you're not supposed to have sophisticated equipment that you will need highly skilled or highly trained personnel to man or to run or to maintain. Universal access is another principle of, and it ties around equity, that people can access the service that is available wherever they are. Community involvement and participation. In establishing a primary health care center, the basic composition of the community is supposed to be considered, and they're supposed to be carried along in setting up that primary health care center, in making the services available, and in ensuring that those services are utilized. I always share the story when I'm talking about community involvement. I heard this story at a training I attended on an HIV training I attended a couple of years ago. So this woman, she's telling us about the fact that this NGO, they had been going into various communities They would talk to them. They would get them to agree to test themselves for HIV. You know, so they would do the pre-test counseling and post-test counseling, give them their results, and then they will come back again and then repeat it with another set of people. Their targets were garages, motor parks, and the like. You know, so in the wisdom of the NGO, at some point, they now decided that instead of going and coming, just going and coming, let's set up a clinic in one of the big garages where those that need their service can come to the clinic, and it will be a more efficient service that they are providing for them. So in their wisdom, they found space. I think they got a container, painted it very nicely, color white, put chair, made the place look attractive. They felt, people will be happy to come into this place. It's better than then just coming and going like a Fulani headsman into the garages and disappearing. So they did, they advertised they will be opening on a particular day. They did mobilization within the garage and the garages around, that this service will be here for you now. We won't be going and coming and all that. The day of the launching, nobody shows up. The second day, the third day, the fourth day, nobody shows up. But at least when we come to this place, at least people hear us. They come to us. They agree to what do So after 5 days of nobody entering the clinic, they had to carry themselves and go back out in their normal Fulani adsman way of walking around with their equipment. And, so they now started talking to the people. But you people are attending to us now. We set up a clinic in your garage to meet your needs. You're not coming there. They were told, when you set up something, you painted it white. So when we enter with our mechanic shirt or with engine oil on our body, you tell us, don't touch the wall, and don't move there, and stay here. And that was the reason why they did not come into the facility, that it was painted white. So they expect that they will not be welcome there. Such a basic thing that if they had discussed with the community prior, they would have known that white is not the way to go to paint something in a garage. But they were using their own mind of, the place looks bright and lively and lovely. For the people you want to serve, you have to find out how they want to be served so that you can meet them at the point of their needs. Because sometimes it is not so much as what you have to offer, it is what the person that you are offering that package is able to accept from your hand. And when it comes to health, it's to deal with the issue of inequity, you must be able to meet the people where they want to be met. So community involvement, community participation is a very key aspect of primary health care. Of course, intersectoral collaboration. I think it's just repetition. So PHC should use integrated preventive, promotive, curative, and rehabilitative services. As I had mentioned before, the focus of health was supposed to move away from curative. Let us stop waiting for people to fall ill and then we treat them. Let's rather equip them with information, with tools, with services that will help them to prevent and protect their health so that their health is promoted and they don't have to come down with those diseases in the first instance. Rehabilitative services, as you should have seen in your note, are services that are required when people have what's the word now? Chronic conditions that cannot be treated, that cannot be managed. Maybe a person was involved in a road traffic accident and is disabled for life, or the person has a cancer that there's no cure, and they need rehabilitation such that they are able to live their best lives, even with that condition that they have. So core components of PHC include education. As well as I've said, we're looking at promoting health. And while research has shown that mere possession of education does not always lead to better action. But when people do not have the education, you absolutely cannot expect them to do any better. So you keep needing to provide information, engaging the clients, reminding them such that they would eventually use this information that they have to improve on their health. As a healthcare provider, whatever practice area you choose to delve into on graduation, community, hospital, even as an industrial pharmacist, you have an undeniable duty to educate the people around you such that they have tools to promote their health. Promotion of food supply and proper nutrition, adequate supply of safe water and basic sanitation, maternal and child health, including family planning, Elias, immunization against the major infectious diseases, prevention and control of locally endemic diseases, appropriate treatment of common diseases and injuries, provision of essential medicines. And we have additional components, including oral health, mental health, and other forms of health that it is expected that each country will incorporate depending on local circumstances that they have within their health system. Some of these additional components include promotion of school health services, promotion of health for the handicapped, safety and accident prevention, care of the aged, occupational health, promotion of referral services. Now, agencies that are involved in managing the primary health care center is divided into various levels. We have at the national level, the National Primary Healthcare Development Agency, headed by a director. And the responsibilities of this agency and the Primary Healthcare Systems Development Department include making basic health services available and accessible to Nigerians, ensuring that the health facilities and services are within reach, ensuring that Nigerians are financially protected against ill health. And this does not mean that they are providing money to the people, but that a form of protected health service through insurance is provided. Building the capacity of its human resource and providing essential logistics support for the implementation of primary health care at the world level. So this department has championed access to health services at the PHC level with the construction of model health centers nationwide with a complement of trained staff providing essential health care. I would mention here that in Lagos, we are slightly more fortunate than most other states because even though at the national level, there's setting up model health centers within Lagos State. Maybe I should just go to okay. Okay, let me finish this with this slide. So, in collaboration with the states, a total of 1,000 primary healthcare facilities in rural communities are engaged with 4,000 midwives under the midwife service scheme. You know, giving birth is a basic healthcare service. And so it is properly within the ambit of primary healthcare center to provide midwife service. In fact, you will find across the country, the major component of PHC that is still standing in many areas is the antenatal and obstetrics and gynecology related services. So you have antenatal services for pregnant women, you have delivery services and midwifery services for those that want to have their children within the primary healthcare center. And then you have postnatal services for the lactating mother as well as the baby. So you have this service that is still working and is still running in many of the primary healthcare centers. Most of the time, the only service left are along with some immunization services, which is also still tied mainly to childcare. So these midwives are trained on life-saving skills and the integrated management of childhood illness programs, such that they have kits, basic equipment, drugs that are required for a safe delivery and a healthy newborn. Excuse me just a minute. You know, and they have health management information systems to capture the data generated from the delivery, from the health service delivery programs that are carried out within this, the PHC. So all that is within the ambit of the at the national level. At the state level, we have the State Primary Health Care Management Board. And I was going to say that in Lagos State, the Primary Healthcare Board has done very much better than most states across the country, because they have been able to develop not just primary healthcare services, but they have what is called comprehensive healthcare services. So they have these centers that provide comprehensive care, and they have a full complement of staff. So while at the usual primary healthcare level, you would have officers, including community health extension workers, community health extension officers, junior community health extension officers. You know, these people are trained specifically in schools of health technology manned by the federal government to provide service at the primary healthcare level. We also have patent. It's not patent. We have what's the word? When I remember, I'll share it. So pharmacy technologists. No, pharmacy technicians. So we have pharmacy technicians also being trained at these schools of health technology to provide basic service at the primary healthcare level. Now, for states that are able to manage it, they have, and you would have seen this in your notes, that there are different levels of service at the primary healthcare level. So you have the health clinics, you have the primary health care clinics, you have the comprehensive care clinics, and the comprehensive care clinics, or model clinics as they are called, have a full complement of staff. So you have physicians that come to the hospital, to the comprehensive care on a daily basis. You have pharmacists that work at the comprehensive care centers on a daily basis. Unlike for most of the other levels at the primary level, where these officers are on supervisory roles. So you will have a physician who has oversight of maybe 5 to 10 primary healthcare centers. So on any good day, he's not anywhere, and everybody else expects it is at the other place, or is at the other place, or is at the other place. So, but for the comprehensive care centers, they have a full complement of staff, doctors, nurses, pharmacists, and physiotherapists, as the case may be, depending on the even lab, depending on the services that are offered at that level. And the referral program goes from one level to the other. So at a healthcare clinic, issues that cannot be managed there will be moved up to the next level, moved up to the next level. So from the comprehensive healthcare center, they're now moved to the secondary care facilities. So the third level of agency are the local, at the local level, where we have the local government primary healthcare authority. I think you'll go through this yourselves. So I'll just quickly look at the organization of PHC, and we can see the personnel. As I said, this is the usual complement of staff in a PHC, headed by the community health officer, who has managerial and supervisory roles. Then the community health extension worker, who is a supervisor, and usually a nurse or a midwife, or could be a technician, a pharmacy technician, or a lab technician. And then we have the senior CHU. They call them CHUs and CHOs. So CHO are called CHO, and CHEW are called CHUs. So we have the senior CHU, who is usually a community health assistant, and then the junior CHU, who is a community health, who provides community health aid, also assistant, auxiliary nurse level, and all that. And then we still have in some primary healthcare centers, I've mentioned that the services provided are sometimes linked to the communities where they are. So you have some primary healthcare centers that work with traditional providers, whether bone setters or traditional healers, or other categories of traditional staff. So this is the structure I was trying to talk about earlier. And as I said, referral moves from one level to the other, depending on what is available within the community. Could be a health post, could be a health clinic, could be a primary health care center clinic, or it could be a comprehensive health care center clinic. And the indicators for evaluating primary health care centers include some social indicators, such as the percentage of the population that have access to improved water source, percentage of the population with access to sanitation, percentage of 1-year-old children fully immunized against TB and measles, contraceptive prevalence rates, because they provide family planning and reproductive services, and then the average annual growth rate in that PHC. So these are some of the indicators used to assess PHC. So I'm going to pause here and open the floor for questions or comments, as the case may be. So if you have a question you want to ask, You can put up your electronic hand so I can see it. Just a minute. No hands are up. Yes, Oyeni is saying that there is no pharmacist and doctor in the organizational outlook. I've mentioned to you when we're talking about primary health care, it's basic health care. So they're not supposed to really have a pharmacist or a doctor in the outlook. As I said, for most of the primary healthcare centers, they have doctors on supervisory visits. They are not really there to work. They are there to monitor what's going on, sometimes support the decision to refer a patient to a higher level of care. And maybe on the days that they are around, if they are not too tied up with paperwork, then they may see a few patients. But basically, that's not the purpose for them to be tied within the organizational framework of the PHC. Of course, with the comprehensive healthcare clinics, the organizational outlook is similar to that of secondary healthcare facilities, because there they have a full complement of staff. So basically, that's that. So since there are no hands up, I will use a few minutes to again run through.
This one is even only one person. She even wants to do plenty things. She wants to cook.
Really?
Happy. Zamba having a long day today.
Odumbaku. Yeah. I would trying to see if this can be. Yeah. Oyeni is raising his hand. Unmute yourself. Go ahead.
Good morning, ma.
Good morning.
I wanted to ask that is there any like means of quality assurance in primary healthcare? Like how do they measure like I don't know the quality of services that they render? Is there any indicator or like means that maybe a team that assesses what they do or something like that?
Well, the last slide I shared was on the indicators for assessing some of the indicators used in assessing primary healthcare services. But the truth is that the primary healthcare service has not worked like it's supposed to have worked. And so right now, no, I don't imagine anybody is really, really assessing what they're doing. Again, I'm going to say that with some caveat, because in Lagos, we seem to have a bit of action in some of the healthcare facilities. And with the COVID vaccine that was tied to primary healthcare, it also helped some of the centers to develop a new life. I was at the Mushin Palm Avenue Primary Healthcare Center yesterday for my second dose of the COVID vaccine. And it was interesting to me that they still have, as I said, their reproductive sexual health program is still very much ongoing. And in fact, I'm thinking of us having an excursion there for my lecture with you on family planning sometime later in the year. But so there's, while there's supposed to be monitoring, but because people are not using these healthcare centers as they're supposed to be using it. Because basically, if people are using the PHCs as they're using it, we should not be treating malaria in the teaching hospitals. We should not be treating some common things, common conditions, diarrhea. Every case comes to the tertiary hospital, comes to Luth, which is not what it's supposed to be. In this note that I have up, you will see that some of the failings, some of the things that supported the failing of the primary health care service is because when it was, when the idea was agreed upon, they now carried it and dropped it in the lap of medical services to implement PHC. Now, when you have given somebody that has always, or not somebody in the sense of a person, but a program that has always run in a particular way, you have said that this program of mainly curative packaging is not what we want. You now say, okay, primary health care, and still give it to the hospital services to implement. So you had all sorts of interpretation for what primary health care should be. So in many of the cases, it was interpreted to mean that, okay, whenever a patient comes to me first, then I'm providing primary health care service. So even if they see me at the tertiary institution, I'm still providing primary health care service. So that defeated the purpose of ensuring that the primary health care service provided the basic health care for the majority of the people. Also, that community mobilization aspect was not well developed. And so you had communities waking up to a primary health care service being delivered to them without them being involved. A classic example I give in this instance is a lot of the times when these politicians, they come to a community with all their noise and their video and their newspaper, Oriyomi Oluwaseun. When these politicians, they come into a community with their newspaper reporters, and they say they are coming to set up water something. They will put a tank, they will put taps, they will set it up, they will take picture, put their face, and generally let us know that they are doing the community a favor by putting the free water in that community. People will use the water, definitely. But once anything happens to that tap, anything up, the tank begins to leak. Everybody will be walking around it because as far as they are concerned, it is Baja's problem. He's the one that puts it there. Or it is Wike's problem. He's the one that set it up. So the tap is spoiled, water is wasting, and nobody is really taking responsibility for it because it is their thing. They came to put it here, but it is really their thing. So it's not our problem. Unlike when a program is established with the community's involvement, you will find out that it will be the members of the community that will be ensuring that you people don't waste our water. You stop talking while you're fetching water. Your bucket has been full since you are still gisting. You know, they have vested interest in the success of the program because they were involved. So again, that didn't happen with primary health care. So people saw it as their program, not ours. So they didn't feel that they have responsibility for it. You know, so these are the things that, part of the things you will see in this note, some additional things that impacted on the success of primary health care. So as I mentioned earlier, there are three categories of tiers of healthcare. So primary healthcare is the focus around which healthcare services in the country is expected to be distributed. I was looking at the current, the most current version of the National Health Policy was produced in 2016. And in that document, they still stated it there that primary health care is still supposed to be the basis around which our healthcare service is distributed. According to that National Health Policy, the federal government is trying to revitalize primary health care to make it more useful, to make it more functional, and to make it more operational to improve the health of the people. So primary healthcare is the first point of contact, or it's supposed to be the first point of contact with the individual, with the family, and the community. So we have examples, as I've said before, the health centers and clinics. It is the closest to the people, and it is the responsibility of the local government. Secondary healthcare is the next tier of health service, and this is within the purview of the state governments. So you have the district or general hospitals, and so there's a certain degree of expertise expected in the secondary healthcare facilities. So the secondary healthcare facilities takes care of problems that cannot be solved at the primary healthcare level, as I said, is under the management of the state government. And then tertiary healthcare, usually a referral or specialist hospital. For instance, our Lagos University Teaching Hospital is a referral hospital and it's tertiary healthcare. And this is the most sophisticated and costly level of care for both the government and patients. And at this level, they handle the most difficult cases because they have a plethora of sophisticated and trained manpower, of sophisticated equipment, and those that can maintain them. You know, I've already talked about the essential components and the principles underlying PHC. Multi-sectoral action, okay. I think all that has been mentioned. So why I wanted to go through this is to see some of the challenges why PHC failed. So there was gross inequalities, and there are still gross inequalities in the health status of the people. The National Health Policy, I said I was looking at yesterday, gave a statistic that 11% of women that are not educated. Only about 11% of women that are not educated have their babies in a health facility, compared to 91% of women that have at least secondary education who have their babies in a health facility. So and this is gross inequity in health. Because this person is not educated, he is somehow or she is somehow denied of some basic level of healthcare that she should have access to. Okay, so there's an article that I put in here, which gives a good overview of health outcomes that are improved at low cost or modest cost in 4 countries, including Bangladesh, Ethiopia, Kyrgyzstan, 5 countries, Tamil Nadu, and Thailand. And this reveals 4 underlying determinants that drive successful health systems. The first is capacity. That is, you have the ability to perform that role. That individual, that institution can do what it is designed to do. Continuity, the stability required for reforms to be implemented, and institutional memory that prevents mistakes from being repeated. The third one are catalysts. So you have the ability to make use of windows of opportunity. For instance, for me, COVID-19 was a catalyst for us in the healthcare sector, and specifically for us in the pharmaceutical sector, because the federal government has either to abandon pharmaceutical services. We don't have capacity to produce any drug because we don't make APIs. We don't have the raw materials to produce the active pharmaceutical ingredients. So when you must import all your APIs, then you are not a producing country. And COVID-19, because of its attendant closures of borders, we have to look inwards. We have to rely on ourselves for our services. Eventually, of course, the borders opened. But what COVID-19 did for health service is that it opened the government's eyes. They couldn't run anywhere. The places they would have run to were already dealt with. COVID-19 dealt with them very well, the places they could have gone. So there was nowhere to go. So they had to stay. And so they couldn't continue to hide their head in the sand and say they didn't know this is how our medical services is. So it forced them to release some money in terms of research. It forced them to start a conversation around our local production of pharmaceuticals. It forced them to start a discussion around health security being a right of the people. Because when people do not have access to health, not because they cannot afford to, if they really have to find the resources, but because the facilities, the medicines, the services are just not there. It's completely unacceptable. So for me, COVID-19 was a catalyst. If in 5 years' time, we'll be able to say we effectively utilize this catalyst, God will spare all our lives to be able to see that time, in Jesus' name. So the fourth one is context. Policies relevant and appropriate to circumstances. I've said that when there are no policies, services that are provided, when there are no policies, services that are provided are at best fragmented. I put a final year student a couple of years to do a study on public health services provided by pharmacists. And it's such a wide range of services that are provided. You have some community pharmacies that do clinics for their patients, so patients that utilize them, that buy their chronic diseases drugs from them. They have monthly clinics for these patients where they talk to them about their drugs. They ask them questions about their adherence, any side effects, generally educate them, so have a day for hypertension patients, have a day for diabetes, have a day for cancer patients. That is one level of public health service. You have those that do health screenings regularly. Some document, some do not document. You have some that say the public health service that they provide is ensuring that their patients have their drugs. Even when they don't have it, they go and source for it from anywhere and go and deliver it to their patients at home. So you have different fragments of public health services being provided across the states and across the country, I'm sure. And that's because there's no policy to tie the activities or the services that are provided to. So this study identified the critical role of access to PHC, and especially access to antenatal care and skilled birth attendants in those countries. In Nigeria, from the mid-70s to mid-80s, attempt was made to put PHC service in place. It turned out to be a failure because during the implementation of the scheme, principles of PHC were not applied. We already know the principles. And I already mentioned some of this. Communities did not participate. The schools of health technology did not equip the trainees with the skills to set up PHC systems. In fact, even these community health officers, community health extension officers were mainly trained on curative services rather than the focus of PHC that was supposed to be promotive and preventive. So you have these CHOs going to the PHCs that they are sent to, and they are attending to patients like they are doctors. In fact, they are referred to as doctors in many of these PHCs because they are providing mainly curative services, which they are not trained, were not trained for. You have the health facilities being equipped with sophisticated equipment that nobody was trained to use. Dental chairs being sent to PHCs when no dentists were sent or trained to, even dental technicians were not trained to go to PHCs. So these are the reasons why the system failed. You see some more information about the population of the various types of centers or clinics that fall within the PHC. And I think I'm going to be stopping. So in this note, you will be seeing a lot more information on the different health services, the promotive health service, the preventive health service, curative, we know that one very well, and the rehabilitative services. I'm not going to go into that. I think I'll just stop here, except there's any other question for me. So for PCL 503, as you already know by now, I'm the coordinator of the course, and from time to time, I will post different assignments on the LMS with time frames that you'll be expected to deliver. I will not extend any assignment, even if the LMS does not stop you from submitting. If you submit outside of time, I will not look at it. I will not assess it. So, and I will not entertain discussions around late submissions, because I will do my best to ensure that I give you sufficient notice for the submission of any such assignments. The next person to take you probably will be uploading lectures, if she hasn't already, according to the lecture flow, is Dr. Olubake, then followed by Dr. Ogbo. And I'll be back sometime in the second half of the semester with the rest of my own parts. As I mentioned here, I'll be trying to see if I can arrange a trip for that will give us some hands-on practical demonstration at a family planning clinic in Lagos. We'll see how that works. So let you know if that comes together. So I think I'll be stopping here since there are no other questions. Okay, so as I said, I think I'm even just repeating myself. Read your notes. If you do have questions, I will be setting up maybe a weekly chat room where you can post any questions and I can respond. I set one up yesterday to put information about this class. I don't know if anybody eventually accessed it, but if you do have questions, we may have that opportunity of a chat room to discuss issues. Sophie Chick, you're sure I'm going to call you because I'm sure that's not your name. And I asked you guys to change your name to a name that I can recognize. If you want to talk, change your name, then unmute yourself. Sophie Chick, whatever that means. Are we waiting for you? Or are we leaving? Sophie Chick. What's the format of in-course? Oyeri Kam is asking. As of today, as I'm sitting here, I don't know. I have not thought about you people and your in-course yet. It's still far down in my list of things to do. But very likely it will be MCQ. And it will be physical. Very likely. Okay, in the absence of any hands being raised, I'll call you back, please. I'm in a class. trying to see if Sophie Kam is still trying to come back. So in this class, we had a maximum of 87 people online. I know that there are well over 100 students. Yeah. Okay then. Bye-bye. Have a good day.